one of the first things that we look at with an implant like this is what is the patient population from a standpoint of people that show up with osteoarthritis that are candidates for a procedure like this?
Sure. These are patients that have been already diagnosed with osteoarthritis, either clinically and typically radiographically. Oftentimes they have much lesser findings of osteoarthritis, much less narrowing the medial compartment, although I've done many with essentially bone-on-bone in the medial compartment. Typically, these are patients that would be considered for unicompartmental arthroplasties and those that have minimal to no significant patellofemoral pain, although I've done many patients that have some spurring and slight narrowing at the patellofemoral joint, even though they really aren't symptomatic from the patellofemoral area. So these are people that are typically too young, too active, and or too large of a body habitus. Their BMI is just too high that you wouldn't consider them ideal or appropriate for a knee replacement arthroplasty. These are individuals that more often than not have failed anti-inflammatories and either have failed or are for some reason not candidates for viscosupplementation, especially those that don't want to have to wear a brace all the time, such as an unloader brace. They're individuals that have often expressed the idea that they would like to avoid such an invasive procedure as an arthroplasty, a complete arthroplasty, or they'd like to put it off if at all possible.
Do these patients typically present with very distinctive findings that allow you to diagnose this type of procedure versus a unicompartmental and or a total?
That's a great question, because since this is such a novel procedure, I really had to adequately be able to answer that. It's really a learning curve, and basically what I've arrived at in answer to your question is there's about a 50-50 split. About half of the patients will point directly to the medial aspect of their knee, and they'll just say, "Doc, this is where it's mostly coming from. This is where I appreciate the pain, especially even walking on level, flat surfaces," when I ask them that question. Another half will just tell me they're really not sure, but it's coming from the knee, and they really can't localize it. So that makes it a slightly bigger challenge. Therefore, we bring into the clinical findings where they usually have a slight increased opening to valgus stress. Their knee is usually stable. They don't have consistent patellofemoral crepitus, or it's felt to be just a chronic finding that isn't contributing to their pain at all. And then we bring in the most important part, which is the standing x-rays, either done in full extension or slight flexion. And we'll usually see some narrowing of the medial compartment with minimal involvement of the patellofemoral. Even if we see some spurring, as long as we don't feel they're symptomatic from the patellofemoral compartment, and certainly not from the lateral compartment, then these are the ideal candidates. Basically, overwhelmingly, just like the clinical presentation of most patients, they're primarily symptomatic from that medial compartment, either diagnosed by what they tell us, the examination, or by looking at the x-rays.
Okay. What advantages does a product like this offer in comparison to the alternatives, being a unicompartmental and or a total?
Well, there's some huge advantages with this particular implant in that it has been based off the proximal tibia, off the tibial plateau. Compared to some predecessors, it's an implant that doesn't involve any major bone cuts. It doesn't involve a fin placement in the proximal tibia, and it doesn't tend to move with the screw-home mechanism of the knee. It basically sits there as a stable implant along the proximal tibia. There's no cement involved, which means there's no cement to crack, and therefore the implant, barring the completely rare event of a dislocation as compared to its predecessors, I think there's only been one individual that's had any dislocations, and I've done the overwhelming majority of these. I pretty much know the data. So we have a stable implant that is completely cementless. There's no fin or bone cuts of significance, to fixate it at all. It's fixated posteriorly with a lip that hangs over the tibial plateau, and it sits there in flexion extension and slight rotation of the knee. So overall, when it can be inserted through a small incision after an arthroscopic assessment for final candidacy and debridements where needed, we have a small implant that's completely minimally invasive, and it doesn't involve some of the issues or concerns involved with even unicompartmental cemented arthroplasties.
Okay. You referenced dislocations as a discussion topic. I'm assuming then in your practice, your implants have remained where placed. They have been stable and have not moved. Can you comment on that a little further?
Well, that's right. There was, in the earliest days of this particular implant, when the instruments were still being designed and where the sizes of the implants were still in transition, there was an implant size that was just disproportionate to the average patient population. So therefore, way back, we're talking 3 or 4 years ago, there was one dislocation. But once the product was matured and in its final state, I haven't had any dislocations. In fact, I've not heard of there being any dislocations whatsoever with this implant. Now, that's a huge difference compared to some predecessors. And the nice thing also is not only is it a very, very stable implant, but it doesn't tend to rotate. So it doesn't tend to produce particulate debris that some other predecessors had. And also, since it's a fixated posteriorly implant with a lip that hangs over the plateau, it doesn't have the potential for loosening from where it's placed originally, let's say with a recess for a fin, in which some of the implant predecessors, such as the Macintosh or McKeever, had that potential. However, very much like some of those predecessor implants, there is I have experienced, at least my patient population has, about an 80% pain relief in about 80% of the patients. That's the stats that I've experienced with my entire patient population.
Great. We'll talk more about pain relief further in this interview. I want to go back to the discussion of stability as just a comment. Statistically, we've seen, like you said, only the one dislocation, which was in the beginning of the development phases, and with 500 plus implants have had no subluxations or dislocations at all. So that's a significant advantage, I think, as to what we've seen with some of the other predecessors, as you've mentioned. To achieve this kind of stability, can you tell me a little bit about your surgical experience? Do you find this procedure to be difficult or more complex than, say, a unicompartmental, or is it the opposite?
Actually, it's the opposite. It is challenging in that to do it reproducibly, it's a little bit more artful as opposed to the involvement of jigs that are much more commonly associated with unicompartmentals or knee replacements, total knee replacements. So whereas it is not challenging to place the implant through a small arthrotomy and to make sure you choose the appropriate size, it is certainly technique driven, and therefore there's a learning curve that does involve some training. And the training, I would say the training can result in a very fast uptake. And once the appropriate techniques are understood, it's very reproducible, and it is basically a procedure that can be done very easily compared to the entire complexity of steps required in a total knee replacement or even a unicompartmental.
Great, thank you. Why don't we address some of the comments you just made previous to this? Can you tell us a little bit about your clinical experience and pain relief that patients do get with the procedure?
Sure. It's important to, as always, with any type of procedure that we're considering, manage patient expectations in advance. So the individuals that are most optimal for this type of procedure are individuals that are open to novel procedures in general. Also, we manage expectations by thoroughly explaining and educating to people where the source of pain is in a typical arthritic knee. And we advise them that this is a implant that tends to do the best when it's combined with other forms of treatment. It isn't necessarily to eliminate all medication. It isn't necessarily designed to even eliminate an occasional viscosupplementation. I tend to be able to avoid cortisone, which is nice to help maintain the residual cartilage surfaces. And I tend to advise individuals that once they have this implant in, the knee tends to take some degree of months to adapt. The nice thing is, while the knee is adapting, they certainly can be fully weight-bearing. They can use crutches or an assistive walking device such as a cane. And more often than not, they're quite pleased with the fact that they don't have this severe bone-on-bone pain from the medial compartment anymore. That is pretty much eliminated very quickly within the first number of visits. They tell me that their knee is completely changed. But I do advise them in advance, and I discuss their expectations, that because of the fact that there are other potential sources of pain in the knee, such as occasional synovitis in an arthritic knee, when we've been able to maintain our natural knee, that sometimes in certain individuals they may require supplementation. The supplementation would be from certain products that are injectables, like a Synvisc or a Supart or Hyalgin, whichever the preference is. From a particular provider, I tend to use all three of them at various times. But again, I have some patients that don't require any injectables at all and rarely require medication. But the key is to just advise the individuals that since it's a metallic implant and because of the Wolff's Law, their particular bone does have to essentially toughen up and harden up as opposed to the metal that it's articulating with. That can take some months of getting used to. The knee can feel a little bit stiff as opposed to the severe pain that they had. And I typically like to ask this question. I ask them in advance. I lower their expectations by asking them if an individual patient, I ask, would you be happy enough with about half as much pain as you've been having? Pain as far as frequency and severity of pain, and how fast it takes an individual's painful knee to become less painful when they're just having their daily activities. I ask them, would they be happy if all of those particular variables could be reduced by half? I really haven't met anyone that says that's not good enough, but I have met some people that don't like the idea of something new. Those are typically not good candidates for this type of implant. However, once I've managed their expectations and I've advised them that their pain relief could be in the neighborhood of 50%, and when typically the pain relief is dramatically better than 50%, and their functionality improvement is also dramatically improved, then they're very happy. I think the key is that not only can they get dramatic pain relief, in fact they do, when I place the implant in the medial compartment, although I've done several laterals, what they find is that their knee is also more stable. So many of our patients, I'm sure many of us have had the experience that patients will tell us not only their knee hurts, but their knee also tends to occasionally feel like it's going to give way. The nice thing about this implant, the implant does dramatically stabilize a knee. Not only is the implant stable, but an individual's pain source from the knee being occasionally unstable prior to surgery, that pain source is eliminated. Now we have a knee after surgery that is much more stable, much less painful, if painful at all, and the occasional discomfort from synovitis in a natural knee that now has an implant inside is very, very treatable and manageable in a way that had never been prior to surgery.